Let's talk about how is it that we can support families with children with neurodevelopmental conditions using telehealth. And to discuss this, I'm so glad to have with me Dr. Sheri Kingsdorf. And Dr. Kingsdorf is an assistant professor at the Masaryk, am I pronouncing that right? Masaryk University in the Czech Republic, and has a doctor level board certified behavior analyst certification. And she has, and she currently is, she recently has and currently is working on a telehealth project that has provided some incredible tools for us. So I got introduced to this because I saw an article that Dr. Kingsdorf was one of the editors of, and I was really impressed by it. And then I found out beyond that, part of this project was where they came up with a toolkit that provides all sorts of documentation, user guides on using telehealth with applied behavioral analysis. So Dr. Kingsdorf, thank you very much for joining us. Definitely look forward to hearing what you've learned in this project.
Great, thank you so much.
Yeah. So I was wondering if you can share what got you started on this project. How'd this project start? What was the goals?
Sure. So it's actually a few different reasons. Like you mentioned, I work at Masaryk University, which, just so people know, is a publicly funded university in the Czech Republic. So that means everything we're working on and doing is being done with public funds, and there's not a profit that comes from anything. So whenever we want to, create materials or provide services to families or do anything like that, we need funding to be able to do this, right? So we're always looking to see, what funding is going to be available. So what we can write proposals for, so that we can help get services to be more available for families, predominantly in the Czech Republic, since that's where we're based. And around the time of COVID, it happened to be the case that there was a call that became available for grant funding related to telehealth, or just technology, I guess, more specific. It wasn't maybe not telehealth specific, but it was a big focus on technology to support or to integrate that technology into whatever research you want to do, or programs you want to develop. So we know that we have this ongoing challenge of providing applied behavior analysis services to children and families in the Czech Republic. And we've been providing a lot of ABA services in different ways, in different formats, in the center that's at the university, or students going into the homes of families, these kinds of things. But during COVID, this kind of all became a real challenge, right? As a public university, we couldn't have, we had very stringent rules, and no one could come into the university. And that was kind of, the end of services for a very long time during some of those COVID closures. And I know
I kind of have an assumption here that it was probably always a challenge for the families to go into a facility for services. But with COVID, not only was it a challenge for the families, but also the clinicians, which made a huge difference. Is that an accurate statement? Has it always been a challenge for families, for many families, to receive services on site?
Yeah, that's absolutely correct. Just because there's such a limited number of ABA, applied behavior analysis professionals in the region, and those that are in the region maybe might be more in the capital, which is Prague, and Brno is the second largest city, which is where Masaryk University is located. So although there's still professionals there, even fewer professionals in that region. So yes, there's always a challenge. You're completely right. And then it became even more of a challenge during the pandemic.
Yeah. And so what are some of the some of the challenges of providing services on site, and how has telehealth helped overcome them? And then we'll move on to specifically working with families who have children with neurodevelopmental disabilities. How does telehealth specifically, help them?
Sure. So I would say that the main challenges were that there are just not enough people to provide services in general. People didn't have the knowledge to go into the homes, to assess children, or to meet with them at the university, right? And so parents were struggling to find practitioners that were kind of trying to do things on their own, maybe at the home, in home with their own children, even just outside of pandemic times, right? Like just in general.
Yeah. And so how does telehealth help with that? Because of course you still have telehealth doesn't magically like increase the number of clinicians, right? So how did
Exactly.
telehealth help address that issue in terms of shortage of clinicians?
Sure. So yeah, of course, it didn't create more people, but it allowed them to do more from a distance, right? So then if it ended up being the case that there's a handful of behavioral practitioners in one part of the country, that they could reach families in another part of the country and take, without having that commute, as a barrier to
So
access.
were you finding that you had ABA clinicians who did not have a full caseload in other areas?
Yes. So the field of applied behavior analysis is really emerging in the region, as it actually is in most of Europe. This is like a new field. And for example, at Massachusetts University, we were running like applied behavior analysis coursework, but not a lot of people would take the courses because they don't know what it's about, and then they take it and they're not exactly sure what they're going to do with it. So it's not actually the case that they would have huge caseloads, because some of these are kind of like new practitioners or students that have just finished their coursework, excuse me. So yes, some of them had availability. And then also some of them, when it became the time of COVID, their availability changed, right? Because they were used to having more intense sessions, like going into a center and working for longer hours, or the commutes back and forth to clients' houses, for example, these types of things.
Yeah. And so in part of this project was that you developed a toolkit like user guides, and it's really impressive. I mean, it seems like you covered all of the things that a clinician would need to know to provide these services via telehealth. Can you talk a little bit about that toolkit and why that was developed?
Sure. So that was written into the project proposal that received funding, as one of the things that we said that we would do would be to create this toolkit, so that way we could help behavioral practitioners who maybe weren't associated with any of our pilot studies to go out and provide telehealth services on their own, and have the means to do that. So we worked to create things like a user manual for them to follow, some video examples of how to do different things, checklists related to fidelity or treatment integrity that they can use, some kind of scripts as well in terms of running sessions. So all of those pieces, so that way they could kind of take it, and it's like they already know how to do behavior analysis, but here's information about how you can do behavior analysis via telehealth.
Yeah, so there was probably a knowledge gap in regards to providing their services via telehealth.
Absolutely.
So that user manual taught them how to make that shift to the virtual environment.
Yes, absolutely. Like the first article I think that you saw, which was a scoping review that I did with my colleagues of telehealth services in Europe. We found that like there weren't any regulations related to telehealth. There wasn't funding related to telehealth. Nobody really knew that much about what telehealth was, and if they did, they certainly weren't thinking about it in the context of applied behavior analysis services for children and their families. So it's just not even on the radar. So not there's no courses teaching it. It wasn't part of, any licensure procedures.
Mhm. Yeah, and I just know from my brief experience working in hospitals doing psych assessments, and where kids would be brought in with neurodevelopmental disabilities and challenges. It was not easy sometimes for the parents to get the kid out of the house and bring them to a place that they're not familiar with. It was very disruptive to the families sometimes, and to wait for their appointment in a facility, and like, I guess that kind of environment wasn't. I would imagine that the home environment seems like it would be much more conducive in some situations. It can obviously provide challenges too, distractions, et cetera. And you don't have the clinician doesn't have things set up the way that they normally would, where they would have control over the environment. But it seems like the telehealth environment, the home environment, a lot of times would be much more conducive. Do you find that to be the case? And then also with the training of the parents. So a huge part of what you work on is actually supporting the parents or the caregivers. So a huge part of it is training them and doing some observing of them working with their children and making those modifications, and then being able to make those direct modifications in the environment where the families are. I would imagine is very powerful. Is that the case? Can you speak to any research around that?
Sure. Yeah, those are really great points, right? You're definitely right in that we working in a different setting, having the parents bring their kids to a different setting for assessments, for program development, that raises a whole nother set of challenges in terms of getting accurate assessment data, avoiding things like, reactivity or the impact that, the new person has on the environment and the behaviors of the kids. And, we can combat some of that when we're using telehealth or when we're working in the home. Not only that, but a big part of applied behavior analysis is that applied piece, that A, and that what we mean by applied is that we want to do what we're doing in the most meaningful context, essentially, right? And so if this kid is spending, 60% of their time or more, really in the home, right? Or even, in school or in their community, whatever it might be, then that's where we want to work on change. Because if we're doing it in the isolation of, my office, that kid's spending, a very small amount of their time there. So that's not where we need to work and not where we need to see the behavior change, really, right? So this kind of telehealth piece or working in the home kind of supports this applied piece of applied behavior analysis, definitely. So I think that was maybe the first half of that question there, right? And then is that right? Did I answer your first part there? Okay.
Yeah.
Okay.
Yeah.
And then the second part was in terms of I think you asked about us working with the families, right? The impact that has on working kind of to make the parents, the change agents, in that setting with their children, or working with their children. Mm-hmm. And yes, that's something we really work a lot on in our third study, which is actually now in press, which is good. So I'll be excited to share that soon, because it also has a lot of resources that have been translated into, in fact, from English to Czech to English again for publication, about how we kind of trained parents to follow protocols to do certain activities with their kids, like how to play with their kids and build rapport in certain ways so that their child's more likely to engage and respond, for example, right? Or to get more language out of their kids. Or to kind of problem solve in positive ways, challenging behaviors with their kids when they're happening. So yes, we've worked a lot to get parents to follow those protocols and those steps and procedures, and training them how to do that via telehealth. And we see that from our results, it is positive. We see that the parents are able to follow these procedures and to change their own behavior, which is really huge in a lot of what we do, actually. It's getting the parents to change their behavior, because then we see that it impacts, everything that's happening, right?
Yeah. So what are some key modifications that are made when going from providing services at a facility to providing it via telehealth?
Sure, that's a good question. I mean, in many cases, what you need to change would be based on what your services look like in the facility versus via telehealth, right? But let's say, for the sake of this question, that the parents did still have an active role if they in the center, right? So the parents came into the center with the child and were still working. You know, you were guiding them or coaching them on the things that they should do with the child, right? So if things already look like that, and then you made the transition to telehealth, some of the things you would probably need to change is you would need to work to get that parent to feel a little more confident on working on their own, or more independent rather, excuse me. So creating user guides for them, you know, kind of step-by-step procedures in layman's terms, and having them available for the parents. That's huge, I would say.
Yeah, and user guides in regards to what? In regards to receiving the services or interacting with their children at home, or what?
Sure. I mean, it could depend on multiple things, right? So we just for sure had these guides in terms of the technological components of telehealth services, right? Like in terms of helping them understand how to set up their computer, how what the camera alignment should look like, you know, how to minimize any windows, how to make sure that they can send videos back and forth in a safe way, anything like this, right? Those all need to be done as well. But then also that they have steps outlined so that they know what to do with their child during the session time without constant feedback from you, right? Because there's less feedback usually that we can give during telehealth sessions, I would say, than when we're in the same room together.
Yeah, and why is that?
Technology issues, definitely. The lag, I would say, which is definitely an issue we see. So, you know, kind of, we try to do this like bug in the ear kind of thing, right? Where they have it in there. We see often that there's still a lag. So, you know, you're saying we could do this, but the time passed to do that, right? And also, you know, it can be a lot for them to manage, right? Like, especially in the home, it can very often be the case that they have a lot more going on than they were dealing with when they were just in the center with you and their kid, right?
Yep.
Right. So kind of all of those extra variables that they probably have to manage if there are pets, if there are other kids in the environment, those types of pieces.
Yeah. Yeah. So it sounds like there's more for the parent and the clinician to manage when they are in real life situations. But then I can also see how being in the real life situation during, you know, the parent training, I guess you could say, or coaching, can also be more impactful because they're addressing what's actually happening in their home environment.
Yeah, definitely. And we can see it as clinicians, which is a great thing too, right? Because, you know, parents can come to you and say, you know, every time I put the plate of food in front of my child at lunchtime, we see, you know, this behavior happen. And so you can work with that parent and troubleshoot it when you're talking about it, but that's a lot different than just sitting there on the computer and getting to see the lunchtime happening, right?
So I can tell you that I have provided counseling to parents in the past, well, children, and then I would work with the families, work with the parents, and I would give these, you know, I'd give this advice and guidance and so forth. Now I'm a parent of 4 kids. So now when I look back, it's like foot and mouth. It's like, what was I thinking? Like that parent was so much more knowledgeable than I was when I didn't have kids. So like, it's so much easier to give guidance when you're not in the environment and having to deal with it yourself. So yeah, it really, when you're actually helping someone in the moment, in the situation, I think the guidance is much more adaptable and fine tuning. It's much more effective, I think, because otherwise we can give a suggestion which can just completely fail. And if we're not right there, then we can't quickly modify. Yeah.
Yeah, absolutely.
Mhm.
It's really true. It's really true. You need to be able to think on your toes, right? And you can only do that kind of when you're in the situation and you see what's
Yeah. Yeah.
actually
Because
happening.
parents have tried things. Like,
Absolutely.
yeah, like I've tried that and it doesn't work. Yeah, I tried that too. And it doesn't, I tried that too, and it doesn't work. And you're like, okay, well, maybe they didn't try hard enough. Well, come to my house with me
Sure.
and you try. So yeah, that's really, it really makes really a shift there. Um
Absolutely.
yeah. Uh so yeah, the user guides, you have a super helpful user guide for clinicians. I've taken a look at it. And then you have a user guide for the parents or caregivers, which is, again, really helpful. Because like you said, the confidence piece is so important. With telehealth, if someone is not sure about the technology and how to set it up, and it's just like a burden, it's not going to go well. But if they feel like they have the resources available, the support available, and it can go smoothly, what a big difference. Do you have like an example of that? And maybe because I'm sure you've had multiple sites doing this kind of work. Have you seen it not go so well in other places that go well?
Yeah, absolutely. We run into, things along the way that we realize we should have done different. All the pieces that came out of this project, they were like our pilots. These two studies were our pilot studies. We definitely realized, things that we should do different. And now, as we are trying to create kind of new telehealth projects that we're going to start, we will take all those things we learned into uh, into consideration. But yes, I think something we learned is that when you have multiple clinicians like we did, who we are trying to train to work with the parents via telehealth, that we kind of need we need more stringent criteria for making sure that clinicians actually are up to speed and understand what the expectations are, because we knew that these clinicians could provide good, applied behavior analysis services. We'd worked with them, we'd seen that, but that's not an indicator that they can do it via telehealth. And I think to some degree, even though we created these resources for them, we still kind of took it for granted that they would, be able to kind of read and do. And I think we actually need even more training for them.
Yeah. And to kind of flip the coin, what are the benefits, or are there benefits? Is there a reason why it would be more beneficial for a family to go to a facility for services rather than just getting telehealth at home if they have good bandwidth? Like if they have good internet speed
Yes.
and the appropriate technology, um, is there any time where like it would be more beneficial, even though they have that, to go to the facility rather than receiving services through telehealth in their own environment?
Sure. So one kind of more simple answer to that is that we kind of have these tools that we created, which are part of the user guide, to kind of identify whether the child and the family are a good fit for telehealth, right? Kind of checklist for them to go through. And for example, if they have really dangerous behaviors that we need to be addressing, then telehealth might not be the best option, being in a safer environment during session where the clinician can, be more available to step in, could be an important consideration.
Yeah, let me ask you about that.
Sure.
So during the session, it
Mhm.
might be safer, right? If they're in the facility,
Right.
but they're only in session for a very short period of time. So if it's a dangerous situation
Mhm.
at home,
Sure.
and you have them come in for the session for treatment, they're still going right back home in the dangerous situation.
Absolutely. It's more of, and that's a good point. It's more of a case that it could be that we have to, that we're trying to develop behavioral procedures then that are a bit more complicated in terms of our responses to them. And we don't have the tools yet really to be able to train parents in the way that we can train, that we should train them to be able to implement procedures on their own, to do on their own immediately. So meaning like we need to model more things for them, right? We need to kind of work more hands-on with the parent essentially, right? Before they can implement the procedures on their own with fidelity and keep themselves safe, right? It's like, I don't want to step in and tell a parent that they should stand here, or they should take this item away, or they should put this item into the session or whatever, until I've done it and see what the consequence is going to be, maybe, right?
Right. Yep.
Yeah.
That makes sense.
But we also had another interesting case in that we kind of did something where we went backwards. So we did these protocols for these telehealth pilots for training the parents, and things were successful. And then we had many Ukrainian refugee families that came within our area and were reaching out for services. So we said, great, like we will use this telehealth program. We will translate everything linguistically and culturally to make it culturally appropriate for the Ukrainian refugee families. And then we'll do this. And then we kind of found that actually they didn't want that. They wanted this, like they wanted to connect with their new community in person. So we ended up taking the procedures, the checklist, all of those pieces, the scripts, and then turning them back into in-person, or turning them into in-person.
Yeah. Now, was it because of the language and they wanted to work with someone that spoke their dialect? Was it the cultural competence piece? Was it them not trusting that they would have a clinician that would understand, their culture?
Yeah, so we did that. So because we ended up hiring 2 Ukrainian refugee behavior analysts at our department. And so they were the people who were going to be providing those services, regardless whether it was going to be telehealth or in person. So I don't know if, if it could have been related to those pieces, or if it was, that there is something to be said for the one-on-one interaction piece as well. And I don't know, we know that there are a lot of other issues that those families were dealing with as refugees to a new place. So just something to also consider, maybe kind of where the families who are receiving services maybe are in their own lives and mental health, to make them maybe available for those types of services.
So I would think it would be kind of like almost like respite, even if it's only for an hour. Right. Meaning the families could be so worn out, and they really want to feel supported, like they're going to go somewhere and they don't have to be the person fully responsible. That there's going to be a facility clinician that's going to be responsible to keep things safe and okay for that period of time, and give them, clear guidance and help. So I wonder, I'm curious if it's that. It sounds like you didn't hear directly, like you really haven't been able to determine exactly what it was that made them want on-site services versus telehealth.
No, not really. We didn't have the answer. We didn't really want to kind of push for responses either, actually. So, it was just that's something that we observed. But I think overall it would be beneficial for there to be more research in general, in terms of like what's needed, how can you assess a family really just beyond their technological environment and the challenging behaviors they state about the child, maybe like what beyond that needs to be in place for families to be successful. Because we saw, like when we first were doing the e-learning course about applied behavior analysis for families in the Czech Republic, we had tons of people respond that they wanted to participate in this free e-learning course. But then the number of people who actually did it, so much smaller, right? Yep. And I think that this, even when we were doing more of the applied pieces, piloting, the families going through those, learning those protocols and applying them themselves, via telehealth, we see like that certain families are more successful than others. So, what is that makes people more successful than others?
Yeah. Yeah, and I'm thinking about the refugees again and thinking, I wonder if their environment that they had available. And then also I wonder, do sometimes families that are just moving, like they're new to an area, I wonder if they're also looking for the provider not only to provide applied behavioral analysis, but also to help facilitate getting them set up with other services. Is that a piece of it or not?
Yeah, I think so. I think that if they're, those families who are in a new place, they're looking to make connections to figure out everything that could be available to support their needs, right? And they kind of see that as a starting point. Like we ran kind of this like behavioral coffee event, we called it, like where we kind of just invited anybody could come in and talk to us about behavioral services. And of course, we provide any other information that we could as well about the region and what else might be available to support their kids who are on the spectrum. And but it's a challenge still because we're not like interconnected services, right? Because applied behavior analysis in the Czech Republic is a recognized profession, but there's no funding for the services, even though it's a recognized
Oh, wow.
profession, not funded by healthcare.
Wow.
So even though we can give them information that we know, it's not like we can set them up like, okay, here is a social worker and they're going to connect you with this service and that service and this,
Yeah,
we don't
I
have these
see.
connections.
Yeah.
Yeah.
Yeah. So the research that you're talking about in terms of, assessing a family and their particular needs and what's going to help them, improve their home situation best, determining what's the best fit for them. I totally agree. I really hope that research happens. That's a really important piece. Now, another question I have is, I know that this is focused on applied behavioral analysis.
Yes.
So clinicians who work with families impacted by neurodevelopmental conditions, but they do not utilize ABA, they use other therapy modalities. Are the user guides that you developed, are they also applicable to other clinicians in other fields?
Yeah, that's a good question. I think that probably some of those pieces would be, right? Like in terms of technology assessment, for example, yes, I think that that could be used across fields. We also developed, I think, or some of the other pieces in there as well are like assessing their acceptability of telehealth services in a more general way, so not specific to ABA. I think that that could be valuable as well. Some of the other pieces I think we had in our guides too related to like, confidentiality agreements, for example, or, contracts, those kind of pieces I think could probably be adapted and be valuable also.
Maybe setting up the technology.
Yeah, definitely. I think there was some technology set up checklists in there also.
Okay. And so it sounds like most of the services provided via telehealth were done through video.
Yes.
Did
Yes.
you utilize other telecommunication, mediums such as text-based or apps or, or just audio only, anything else?
Yeah, no, we really mostly just were using like Zoom, for example, most often. We don't actually have to deal with, what would be like akin to HIPAA compliance in America. That's not an issue that we have to deal with in terms of the ABA services. So in that regard, maybe, we're a little more free in what we can use, or even the transmission of video, although we still try to adhere to all of those appropriate pieces, right? But one thing that we found out like almost immediately was that clinicians told us they did not really want videos sent to them. They had said that they had kind of dealt with this in the past, and they found that when parents were sending the videos, it was hard to figure out the context of the video, and then they would spend time watching the video and they would have, not necessarily as much takeaway, and then they try to give the parents feedback about the video, but 100 things have happened since they sent the video. So, we kind of right off the bat had this because we were going back and forth whether we should have them send videos, and our clinicians just kind of said no, they didn't want that. So because of that, we changed to doing everything live, via video meetings. That was always
Yeah.
the aim. If there was a problem with the video bandwidth, then we would turn off the cameras, but otherwise, that's what we did.
Okay, that is super helpful. That will save people time.
Yeah.
Because yeah, a lot of training of parents has happened through sending video clips and then giving feedback about the video clips, the
Yes.
asynchronous method.
Yeah.
So yeah, so that's very interesting. Well, thank you so much, Dr. Kingsdorf, for the work that you're doing, and thanks to the project. And I really hope to hear more, as more research comes about.
Great. Well, thank
And
you so much for having me here to speak about it. I'm very happy
yes,
to share the information.
and links to the project and to the toolkit, the user guides, will be in the description. Yep,
Great. Thank
thank
you
you.
so much.